control hypertension. Now, what does antihypertensive drugs mean? So they basically control hypertension, and there are various mechanisms, as you guys already know, to control hypertension within the body. So we have diuretics as one class. Second class includes drugs acting on RAS systems, such as the renin-angiotensin-aldosterone system. Then we have adrenergic agents and calcium channel blockers. In this video, I'm going to be going into detail on diuretics, adrenergic agents, and calcium blockers. And I'm going to leave the drugs on acting on the RAS system, i.e. the renin-angiotensin-aldosterone system, to another video because there is a lot of classes of drugs within that class, and I wouldn't be able to do this in this one short video. There are also vasodilators. Now, let's start with diuretics. What are the family and classes of diuretics? So we have saluretics, which is the first class within the diuretics. Within saluretics, you have thiazides. Thiazides include hydrochlorothiazide, chlorothalidone, and indapamide. You are most probably likely to heard of somewhere within your clinical practice of indapamide. We also have a second class within the saluretics class, known as loop diuretics. So we have diuretics, which is a class itself, or an umbrella term, which controls antihypertension. So it's antihypertensive drugs. Within that, you have saluretics. Underneath saluretics, you have two subclasses known as thiazides and loop diuretics. Loop diuretics include furosemide and torsemide. And finally, the second class, we have potassium-sparing diuretics, which include aldosterone antagonists such as spironolactone. So what are the mechanisms of action, and how do diuretics work? So in this video, in this slide, we're going to be talking about saluretics, especially thiazides, so indapamide, hydrochlorothiazide, and chlorothalidone. So on the screen, on the top right, you can see the distal convoluted tube of the kidney. So you're aware that in the distal convoluted tube, you have a sodium chlorine transporter, and you also have a sodium potassium pump on the interstitial side, and on the luminal side, i.e. where the urine is, you have a sodium chloride pump. So the way it works is, usually the drug, i.e. the hydrochlorothiazide or the chlorothalidone or the indapamide, usually blocks the sodium, where the sodium chlorine channel, simple, where my mouse is pointing now. So upon the blockage of this, what then happens is you would have excretion, i.e. because there's a urine, where the mouse is pointing now, because this is the urine side and this is the blood. There is no further reabsorption of sodium and chlorine back into the blood. So therefore, there will be increased excretion of sodium and chlorine, which decreases osmolality within the blood. So therefore, more water, because there's increased osmolality within the urine, i.e. the osmotic pressure is favoring traveling of water towards the lumen of the urine, more water will move out. So therefore, the blood volume within the interstitial blood, i.e. the blood volume in the blood, will decrease, leading to decreased venous blood flow, hence decreased peripheral resistance, so therefore decreased hypertension. There's also increased loss of potassium and enhancement of Ca2+, i.e. calcium is reabsorbed. Since there's reduction of uric acid secretion in the proximal tubule, secretion of drugs by the organic acid system, i.e. the OAT system. For now, from this, all I want you to remember is thiazides block the sodium chlorine channel, so therefore there's further excretion leading to decreased osmolality within the interstitial blood and increased osmolality within the luminal urine. What are the extrarenal effects? So we have vascular smooth muscle K+, so potassium opening, which leads to vasodilation, and you have decreased insulin production, so therefore this will lead to hyperglycemia. So another thing to keep in your mind is, when you administer thiazides, just remember that this would eventually cause hyperglycemia. Indapamide is usually orally administered with a half-life of 1 to 2 hours. Hydrochlorothiazide has a greater half-life at 20 to 40 hours, and it has the highest bio-oral availability in terms of the thiazides within the saluretics family. What are the adverse reactions and contraindications? First of all, you can see on the bottom right hand side, the contraindications are shown in the purple color. Diuretics, especially saluretics or thiazides, are contraindicated in both gout and pregnancy. The reason why gout is contraindicated is because we know there's a reduction of uric acid secretion in the proximal tubule. Also, it's contraindicated in pregnancy. Now, the common adverse reactions or the side effects include hyperkalemia because of enhanced potassium loss, increased uric acid production, and you can also lead to diabetes development, as we said, extrarenal effects because of the hyperglycemic effect. You might also develop cancer of the skin, and you might also end up having hyperlipidemia. The main one to remember is hypokalemia. Diuretics usually cause hypokalemia. Because of hypokalemia, you can develop hypotension and maybe even lead to atrioventricular block, causing headache, flush, and dizziness. The ones I want you to remember is hyperkalemia, increased uric acid, diabetes development, cancer, and hyperlipidemia. There are further ones which I have not included in this video. Now, indapamide. What are the mechanisms and actions of indapamide? Indapamide again comes under the class of thiazides, so we did hydrochlorothiazide and chlorothalidone, the mechanism of action. Indapamide. The way indapamide works is it has a vasodilating effect, so it affects the calcium channel and increases prostaglandin E1 and prostaglandin I2. It's orally administered with a half-life of 1 to 2 hours, and so it's the oral bioavailability is the shortest compared to the rest of the thiazides. Hydrochlorothiazide has the longest oral bioavailability. The side effects of indapamide usually include hyperkalemia and hyperuricemia. The only one thing I want you to remember from this is vasodilating. The mechanism of indapamide is it usually causes a vasodilating effect by calcium channel blocking, leading to increased prostaglandin E1 and prostaglandin I2. So it's a weak diuretic action. It has a weak diuretic action, and the side effects are hyperkalemia and hyperuricemia. Loop diuretics. We said loop diuretics within the class of diuretics included furosemide and torsemide. You can see furosemide has the highest oral bioavailability at 4 to 6 hours, and torsemide at 1 to 2 hours. They also work in the thick ascending limb compared to the previously we mentioned the saluretics, which worked in the distal convoluted tube. So you can see on the top right, I've highlighted as distal convoluted tube. The loop diuretics, on the other hand, works in the thick ascending limb. Now, how do they work? So the mechanism of action is they inhibit the sodium potassium chlorine synthol. So you can see here on the luminal urinal side, there is a 3 electrolyte type transport of sodium, potassium, and chlorine. They block this, so therefore there will be decreased reabsorption of sodium, potassium, and chlorine. So therefore, all three of these, when these three things cannot go back into interstitial blood, obviously the osmolality in the lumen would be increased, and it would be decreased in the blood, so therefore causing water to move outwards. They also affect the limb of loop of Henle, but the main thing I want you to remember is the thick ascending limb. The renal effects include increased excretion of sodium, chlorine, potassium, calcium, and magnesium. Side effects include hyperkalemia, hypermagnesemia because of the loss of increased magnesium, hypercalcemia because of loss of calcium, hyperglycemia, hyperuricemia, and the main and key ones to remember here are they cause ototoxicity as well as allergic reactions. So if you have an MCQ in exam saying which type of diuretics causes ototoxicity, then the answer would be furosemide and torsemide, which come under the class of loop diuretics because they affect the loop of Henle, loop diuretics. Now, potassium-sparing diuretics, which was the final class within the diuretic family, this included one main drug, which I want you to remember was spironolactone and eplerenone. But the one I want you to remember is spironolactone. They work on the collecting tubules, so as you can see on the bottom of here. The way they work is, the mechanism of action is they inhibit the sodium reabsorption in the collecting tubules. They also cause inhibiting effects of the aldosterone. You know, aldosterone is a hormone which controls sodium reuptake in the collecting tubules. So if they inhibit the effect of aldosterone, therefore decreasing amount of sodium reabsorbed into the collecting tubules, again causing increased osmolality within the luminal side of the urine, causing water to flow out. The trimethoprim inhibits the sodium channels on the apical membrane. With trimethoprim is also a third class of drug which were involved within the potassium-sparing diuretics, so spironolactone, eplerenone, and trimethoprim. Remember trimethoprim. I have not included trimethoprim within the box here, but it is included here. Now, they're orally administered, and the side effects usually include hyperkalemia this time. Usually all the other times with furosemide, torsemide, which was loop diuretics, you had hypokalemia. With the thiazides, you had hypokalemia, but this time with potassium-sparing diuretics, it's the opposite side of thing. You have increased potassium. There's also GI disturbances. It can lead to gynecomastia, an endocrine issue, prostate hyperplasia, kidney failure, kidney stones, and allergic reactions. So it's best, when you think about it, out of the diuretics, the most safest or the most harmful drug out of all of them, probably most likely to be potassium-sparing diuretics. Keep that in your head. Hyperkalemia, GI disturbances, gynecomastia, kidney failure, kidney stones, prostate hyperplasia. Now, what are another class of drugs which cause antihypertensive effects, i.e. decrease hypertension? These include androgenic drugs, i.e. beta blockers. They can be split into both two classes, non-selective and selective. So non-selective basically means these drugs can affect both beta 1 and beta 2 receptors, whereas selective only affects beta-1. There's only one drug that I want you to remember as a non-selective, which is propranolol, and the selective one, usually the one I want you to remember, is metoprolol and atenolol and bisoprolol, so all the lols. So the non-selective one is propranolol, the selective beta-1 is metoprolol, atenolol, bisoprolol. I have not gone into detail in this video of the side effects or anything, because there is a separate video explaining androgenic receptor blockers. There is also vasodilating effects, such as carvedilol and nebivir. The way the mechanism of action usually is these drugs cause decreased cardiac output, so therefore, cardiac output is equal to stroke volume times heart rate. So if these drugs, when they act on beta-1 receptors, selective ones, usually beta-1 receptors are found in the cardiac muscle tissue, they decrease the heart rate, therefore leading to decreased overall cardiac output. When you have decreased cardiac output, you would also have decreased blood pressure, because of the fact that blood pressure is cardiac output is equal to heart rate times peripheral resistance. They also cause decreased release in renin. Renin is released from the kidney, and renin is involved in the RAS, renin-angiotensin-aldosterone system. When there's increased renin, they cause increased production of aldosterone, and also angiotensin 2. Angiotensin 2 is a potent vasoconstrictor which would cause increased hypertension. Aldosterone would increase the reabsorption of sodium, which would then cause, again, hypertensive effects. They also have presynaptic beta blocking effects. Finally, we have calcium channel blockers. There is a separate video completely on the mechanism of action and exactly how calcium channel blockers work. For this purpose, I've just quickly highlighted and labeled all the different types of calcium channel blockers. So in calcium channel blockers, we have two types of calcium channel blockers. We have DHPs and non-DHPs. DHPs include dihydropyridines, and non-DHPs include are basically non-dihydropyridines. These guys, the non-DHPs, work directly on cardiac muscle, whereas DHPs usually work on blood vessels or the coronary arteries. The first generation includes nifedipine, nitrodipine, nimidipine, or they are orally administered with a half-life of 3 to 4 hours. Second generation, felodipine and nifedipine. The most common one that you probably have heard of is in the third generation, because of the reason it has the highest oral bioavailability, amlodipine, which has a half-life of 20 to 50 hours. Within the non-DHPs, the lowest oral bioavailability, lowest, not highest, lowest oral bioavailability is from verapamil, which has an IV administered. All the drugs that we've gone through so far in this video have been orally administered, everything, so apart from verapamil, which is a non-DHP calcium channel blocker. This is administered IV. It has a low oral bioavailability and a half-life of 3 to 4 hours. What does verapamil do to the, how does it act? It has a negative chronotropic effect, i.e. it decreases the SA node firing. It has a negative dromotropic effect, so it decreases the AV node firing. And it also has a negative inotropic effect, which is the contractility. So therefore you can imagine when these three effects combine together from the result of verapamil being administered, it causes heart rate decrease, leading to decreased hypertensive effects. Diuretics also has similar effects with negative chronotropic and negative dromotropic effects. You can see the DHPs, first generation, are usually, all DHPs are basically affect the blood vessels, whereas non-DHPs, like I said, affects the cardiac muscle. The first generation can also be given with someone with acute asthmatic effects, because these drugs can also cause bronchodilation, and they can also be given, especially nifedipine, can also be given in intrauterine during pregnancy. What are the contraindications of calcium channel blockers? The only beneficial one is dihydropyridines can be given with beta blockers. Beta blockers affects cardiac muscle tissue, whereas dihydropyridines causes effects on the blood vessels, or the small blood vessels, the coronary blood vessels. So together they can cause decreased hypertension. Non-DHPs and beta blockers are contraindicated because they both affect the cardiac muscle, which would then cause probably a decrease in heart rate, leading to bradycardia and heart failure. Verapamil and digoxin are also contraindicated because of the fact that they affect the heart muscle, and they're also calcium channel blockers are contraindicated in congestive heart failure. And so that's just a summary of everything that you need to know. There's another video on how the RAS system, i.e. drugs affecting the renin-angiotensin-aldosterone system. This is just a quick overview, just so that you can have an understanding of which drugs are used in the pharmaceutical industry in order to control antihypertensive mechanisms. Thank you for watching, subscribe and share.